Okay, let's dive right into this. Have you ever tried to swallow something and it just feels like it gets completely stuck right in the middle of your chest? Right? For most of us, a quick sip of water clears it up instantly. But imagine if that feeling literally never went away. Imagine a muscular door inside your body that simply refuses to open, no matter how hard you try to eat or drink. Today, in this explainer, we're exploring a deeply fascinating and honestly pretty intense medical mystery called esophageal achalasia. We're going to examine exactly what happens when the lower esophageal sphincter, that vital biological valve separating your esophagus from your stomach, just completely goes rogue. In this explainer, we'll cover our agenda step by step. 1. A brief definition. 2. The pathophysiology. 3. The clinical manifestations. 4. Medical treatment. 5. Surgical treatment. And finally, 6. Nursing management and lifestyle monitoring. Okay, let's kick things off with part 1. A brief definition. The very name of the disease tells you exactly what we're dealing with here. Achalasia comes from the prefix a, meaning without, and chalasia, meaning relaxation. So it literally translates to no relaxation. It's kind of like a locked door. Normally, when food travels down your esophagus, the lower esophageal sphincter acts as this incredibly efficient sliding door. It relaxes to let food drop into the stomach and then tightly shuts to keep all that harsh stomach acid from splashing back up. But in achalasia, those muscle fibers just fail to relax. The door stays firmly, stubbornly jammed shut. And on top of that, the esophagus loses its ability to squeeze food downward, a process we call peristalsis. So food tries to enter the stomach, but it literally has nowhere to go. Moving right along to section 2, pathophysiology. Let's look under the hood. So you might be wondering, why does this muscle fail to relax in the first place? Well, it turns out this is a severe neurological miscommunication. Our esophageal pressure is normally regulated by the super delicate balance of neurotransmitters. You have excitatory ones like acetylcholine telling the muscle to squeeze and inhibitory ones telling it to relax. But in people with achalasia, there's a massive absence of inhibitory ganglion cells. The body essentially loses the very nerve cells that deliver the relax signal, causing this huge chemical imbalance. The result? A hypertensive, permanently flexed muscle. And what's really wild is that studies suggest this might actually have an autoimmune context, potentially triggered by a virus early on that leads to inflammation, completely destroying these absolutely crucial nerve networks. Now, if you look at this actual microscopic view comparing normal tissue to achalasia tissue, the key culprit missing here is an enzyme called nitric oxide synthase. In a healthy body, this enzyme generates nitric oxide, which is essentially the potent chemical key that signals the sphincter to relax and open up. But in patients with achalasia, as you can see by the total lack of dark staining in the bottom image, this enzyme is completely absent at the gastroesophageal junction. Without that nitric oxide, the molecular lock simply cannot be turned. No key, no entry. All right, let's transition to section 3, clinical manifestation. What does this actually look like for the patient? The macroscopic effects on the patient's day-to-day life are frankly severe. The absolute hallmark symptom here is dysphagia, which is a progressive, distressing difficulty in swallowing both liquids and solids. Because the food can't pass into the stomach, patients often experience the regurgitation of completely undigested food. They also suffer from intense non-cardiac chest pain, known as cardiospasm. And this pain can be so agonizing that people frequently mistake it for a full-blown heart attack. Plus, because almost no food is making it to the intestines where nutrients are actually absorbed, patients face progressive, sometimes extremely dangerous weight loss and starvation. It is a really tough road. And here is where things can get worse. It's what we call the snowball effect, megaesophagus. Think about what happens when a biological hallway just backs up over time. If left untreated, all that trapped food and liquid continually stretch the walls of the esophagus out. On an X-ray barium swallow study, you'll see this massively dilated esophagus tapering down to a sharp, tight point right at that jammed sphincter. Doctors call this the classic bird's beak or rat's tail appearance. The esophagus essentially turns into a stagnant reservoir, and that puts the patient at a huge risk of inhaling this trapped food into their lungs or developing severe infections like candidiasis, which, by the way, is a major risk factor for esophageal cancer later on. Okay, so how do we fix it? Section 4, medical treatment. Our very first line of defense usually involves non-surgical attempts to literally break the tension. We can try chemical lockpicks, like injecting botulinum toxin. Yes, we're talking about Botox. They inject it directly into the lower esophageal sphincter to temporarily paralyze the muscle holding that door shut. But it is just a temporary fix. It wears off in about 6 months, so it's usually reserved for elderly or high-risk patients who can't undergo surgery. The more common physical approach is something called pneumatic dilatation. Here, a deflated balloon is placed inside the sphincter and forcefully inflated to physically stretch and actually tear the tight muscle fibers. It's super effective, especially for patients over 40, but the body can heal from this trauma, which means they might need repeat procedures with even larger balloons down the line. When medical management isn't enough, we turn to Section 5, surgical treatment. Okay, this is absolutely fascinating. One of the biggest advancements here is the POEM procedure, peroral endoscopic myotomy, which was first developed in Japan back in 2008. Instead of cutting through the patient's abdomen, a surgeon inserts an endoscope straight down the mouth. They make a tiny incision inside the esophageal lining, physically tunnel down beneath the surface, and precisely slice the inner circular muscle of the sphincter to release all that tension. Because it's done entirely from the inside through the mouth, there are literally zero visible external scars on the patient's body. None. And they can often get back to eating a normal diet in just days. It's a real game changer. Now, this amazing technique actually builds on the established gold standard, the laparoscopic Heller myotomy. Named after Ernest Heller, who pioneered it way back in 1913, this is the classic surgical 1-2 punch. First, the surgeon makes a lengthwise cut along the outside muscle layer of the esophagus, leaving the inner lining totally intact. But here's the catch. Once you destroy that sphincter muscle, the door is permanently wedged open, which puts the patient at massive risk for severe acid reflux. So to solve that, they perform a partial fundoplication, like a door or toupee wrap. They literally wrap the top part of the stomach around the lower esophagus to create a brand new artificial pressure zone. It keeps the acid down, but still lets the food pass through. Brilliant, right? Moving on to our final phase, Section 6, nursing management and lifestyle monitoring. From a nursing management perspective, patient education is absolutely critical here. These individuals now have to rely almost entirely on gravity and careful routines just to digest their food. Nurses have to instruct patients to eat slowly, chew their food incredibly thoroughly, and drink plenty of water to literally wash the food down. A huge nursing intervention involves making sure the patient sleeps with a wedge pillow. This uses gravity to prevent nighttime aspiration into the lungs, which is super dangerous. Nurses also monitor the use of proton pump inhibitors, or PPIs, to suppress stomach acid, and they heavily educate patients on avoiding reflux trigger foods. We're talking citrus, ketchup, chocolate, all the fun stuff, unfortunately. And of course, making sure they stick to lifelong follow-ups, like annual barium swallows and endoscopies, is absolutely vital. All right, let's bring it all together for the key takeaway. Back in 1929, two physicians, Hurst and Reek, finally hit the nail on the head. They realized the problem wasn't a muscle spasm at all. It was a failure to release. They coined the term achalasia. And almost a century later, that phrase, an inability to relax, still perfectly, elegantly defines the daily struggle of these esophageal muscles. It remains the primary target of literally every single treatment we use today. To put all this into perspective, achalasia is quite rare. It affects only about 1 in 100,000 people per year. You might actually know that the famous planetary scientist Carl Sagan lived with it. And while it does remain an incurable, lifelong condition, just think about how far we've come. We can take a patient who is literally starving because of a microscopic missing enzyme and structurally rebuild their digestive plumbing. Thanks to incredible surgical innovation, it is a highly manageable condition today. I want to leave you with this thought. We just talked about the POEM procedure, literally tunneling under the skin of the esophagus from the inside out to permanently fix a paralyzed muscle without making a single external cut. As this incredible minimally invasive technology keeps evolving, what other seemingly impossible internal blockages across the gastrointestinal tract might endoscopic surgery conquer next? The future of medical engineering is looking more precise and way less invasive than ever before.